In this dementia lecture, you're going to have to do two things. One, compare the different types of diseases that are going to present with memory loss, and then know the different types of dementia. Let's start off on the first half of this lecture talking about those disorders which could have cognitive impairment and memory loss, separating them from dementia. There's three I want you to consider: dementia, amnesia, and delirium. When you actually see these in people, it is not hard to separate. But as you begin learning, it becomes a little difficult because when you put them in tabular format, they look very similar. Dementia can have cognitive impairment or memory loss. So too can delirium have cognitive impairment or memory loss. Amnesia is just memory loss, but no cognitive impairment. They can do everything else normally, they've just lost memory. So what am I talking about cognitive impairment? What I'm going for is the different neuropsychological domains that you do not have to memorize, but it's things like the ability to attend to something important, multitask, executive function, speech, vocabulary, and memory. When these things are lost, the person becomes less able to do life. They become less like a person, and that's what makes us different than all the animals. It's our higher level of cortical function, and as you begin to lose that, you begin to get demented. So, no cognitive impairment, but memory loss and amnesia. So what's the difference between dementia and delirium? Delirium is altered mental status. It is acute, and it is overt. And you will find that it waxes and wanes over time. This is the person who has an insult. They are altered. If you fix that insult, they get better. This is the old person with a UTI presenting with sepsis, or your friend on a Saturday night drunk at the club. Whatever the case might be, they're altered, and if you fix the thing that caused them to be altered, they'll go back to normal. Whereas dementia is chronic and insidious, and it is permanent. You assess them at the beginning of the day, at the end of the day, or a week later, chances are it's going to be exactly the same, whereas the presentation in delirium might change over time. So once you get into the bucket of dementia, what we're going to be talking about in this lecture, there's another spectrum of disorders, and dementia usually affects the elderly, so we want to compare normal aging to what's called mild cognitive impairment to dementia. Now, there is no way of definitively diagnosing dementia. But what we do is we run patients through the gamut of subjective testing that tests those neuropsychological domains. We used to use the mini mental status exam, less than 22, you've got dementia. But now it's proprietary, so it costs money to use. So you won't see it on the test, and chances are you're not going to see it on the wards. Just recognize that there are some tests that you can do that tests different areas of cognitive function. If you test positive, you have cognitive impairment. So the way I look at this is say, normal aging is going to be test negative, whereas mild cognitive impairment will be test positive, as will dementia. And normal aging, because they have no cognitive impairment, their level of function is maintained. They're function positive. In dementia, when it's really bad, they have the disease and they lose function. They're function negative. But mild cognitive impairment is not normal aging, but not yet full dementia. That is, they maintain their level of function. And by function, I mean they can act independently in society. They might have to drive only very close to their home and do very simple math, but they can still live on their own. Once you're at full-blown dementia, people got to take care of you. So the way I want you to see this is the person with normal aging is the person who's going to have trouble remembering their grandkids' names or losing their keys about their house. But there's no functional impairment. The mild cognitive impairment is going to be someone that has evidence of dementia, but still maintains a level of function. They're able to pay their bills, feed themselves, go grocery shopping. They just have lost a little bit of their memory, and maybe they need their spouse to kind of pick up the slack. Someone who's got full-blown dementia might have complete loss of function in the way of not being able to remember except for 20 years ago, or have lost all of their social graces. And this is going to be where we go for the back half of the lecture when we talk about the different types of dementia. But you ruled out amnesia, you ruled out delirium, and here you are now at dementia. It'd be nice if you could reverse it. But we know that it's chronic and insidious and permanent. But there are some reversible causes that look like dementia but aren't. To find them, you're going to look at a TSH and T4 for hypothyroidism, a BMP looking for creatinine and a BUN, LFTs for evidence of cirrhosis, vitamin B12 because B12 deficiency can present looking like a dementia. Back in! An RPR to rule out neurosyphilis, and screen for depression. Pseudodementia, that is actually depression in the elderly, especially after the loss of a spouse, is a very easily reversible cause of dementia. And if you have definitively diagnosed dementia and ruled out these reversible causes, you want to get some sort of brain imaging, either CT or an MRI. CT is the preferred choice because what you're looking for is degenerative changes, hydrocephalus, and maybe a subdural hematoma, which the CT can pick up. The MRI is better for things like Creutzfeldt-Jakob and strokes, but you're generally going to get that on the history. And if you find a reversible cause, go ahead and reverse it. But if you can't find any reversible cause, you've got real organic disease, and then you're just going to have to diagnose it. This is the discussion you're going to have on the wards. Is it mild cognitive impairment, normal aging, or dementia? And then what's the difference between dementia and delirium? Know that you have to do these tests in order to try to reverse the underlying cause, but where the test is going to go is how do you recognize what dementia this person has right now? And that's what we're going to be talking about on the back half of this lecture. Let's start off with the most common, that is in the way of prevalence, and the one you probably are going to recognize, Alzheimer's disease. Alzheimer's disease is caused by plaques and tangles. You probably learned about this for step 1. Now we have the ability to look at the brain and see how much of these plaques are present. We can get tests from the blood to test for the protein that's going to cause these things. Don't do that because we don't have any way of treating Alzheimer's. Remember that these plaques and tangles are there and that there's an association with chromosome 21, but beyond that, don't actually use that information clinically. Instead, what you're going to do is identify the person who has Alzheimer's. In Alzheimer's disease, the memory goes first. Or the person who has Down syndrome, because of that association with chromosome 21. The person is older, elderly, chronic, insidious loss of memory, first the short-term memory, then long-term. And eventually the person thinks they are the person they were 20 years ago, and they cannot remember up to this date. So chronic, insidious loss of memory is Alzheimer's disease, and it usually spares social graces. The diagnosis is clinical. But because we know we're going to get a CT scan for all of our dementia patients, look for diffuse cortical atrophy. As we'll learn, most of the causes of dementia are irreversible, so the treatment comes down to supportive care and family education. Although we are right now attempting to use acetylcholinesterase inhibitors like Tacrin and donepezil. These probably don't work, but anything that delays the progression of Alzheimer's is good because it gives the patient a higher quality of life. Let's compare Alzheimer's disease to Pick's disease. you won't see it called Pick's disease on the test. Instead, you'll see frontotemporal degeneration. And as the name implies, the frontal cortex and the temporal lobes are what's taken. I still like to coach Pick's disease because the patient presentation in Pick's disease is that the personality goes first. This is a person who's going to retain memory but lose the filter. They become hypersexual, hyperaggressive. They won't have anything that says, I probably shouldn't say that, or I probably shouldn't do that. They'll just go ahead and do it. The diagnosis is clinical, but if you got any imaging, you're going to see frontotemporal degeneration. Now, eventually, the memory will go in Pick's disease, but the personality goes first. Eventually, the personality will go in Alzheimer's, but in Alzheimer's, memory goes first. In both cases, the treatment is supportive, not too much to do about it. Lewy body dementia is essentially Parkinson's. The pathology of Parkinson's is Lewy body. The pathology of Lewy body dementia is the Lewy body. So what you're looking for in the patient presentation is going to be someone who has Parkinsonian symptoms. It looks like they've got Parkinson's and they have dementia. Now this is frustrating because there's two different diseases, Parkinson's with dementia and Lewy body dementia, both of which present with dementia and Parkinsonian symptoms. Lewy body dementia has the dementia predominate with a few Parkinsonian symptoms. Parkinson's with dementia has primarily Parkinson's, and then they end up with dementia later. In the vignette, though, what you should look for are visual hallucinations. If you see visual hallucinations in a dementia question, the diagnosis is done, Lewy body. The diagnosis is strictly clinical. You can make the diagnosis on autopsy, that is a biopsy, but no real brain imaging is going to help. They may throw at you the fact that there was an MRI done that showed the loss in the substantia nigra. They're basically giving you the question for free, but don't order the MRI in order to figure that out. If they offer that information, great. Treatment is supportive. The last of the major four is vascular. Vascular dementia has to do with strokes. And the patient is going to have a stepwise decline with each stroke. Now, it is insufficient to say, this person has dementia, and I've done brain imaging that shows strokes. The thing is that people who get Alzheimer's are old. They might have vascular changes in their brain, and they might have had a stroke. So the presence of infarct does not mean vascular dementia. It must be the stepwise decline, such that their cognitive function plateaus, they have a stroke, their cognitive function remains the same, they have a stroke, cognitive function remains the same. So each insult causes a stepwise decrease in function, and it's not a gradual decline as in Alzheimer's. The diagnosis is clinical, but if you got the CT scan, you might see evidence of infarcts. The treatment is to treat the stroke, but it's supportive for the dementia. These are the four you're really going to compare against each other, but there are two others that are so obvious that it's worth talking about because it's easy to write a test question about them. That is Creutzfeldt-Jakob disease, which is caused by prions. Now, you probably learned mad cow disease, undercooked meat, right? The vast majority of patients with CJD didn't get it from undercooked meat. Most people get it from sporadic mutation. And the way the patient is going to present is actually very unique. It's going to be really young dementia. Look for the 30s and 40s. Who has myoclonus. Myoclonus and young dementia. You have the diagnosis of CJD. The diagnosis can be made on MRI, and the treatment is supportive. They usually die within 6 months of the diagnosis, either self-inflicted or from an infection. Now we're going to end on one that has a little bit higher note than CJD, and that's normal pressure hydrocephalus. The pathology here is an increased intracranial pressure. Now, we don't really know what causes it, so it's normal pressure hydrocephalus, but the brain feels an increased pressure because when you relieve the pressure, they get better. So the patient is going to present wet, wobbly, and weird. That is, they're going to have urinary incontinence, gait ataxia, and dementia. The diagnosis is made on a CT scan, which shows hydrocephalus. The confirmatory test is do a lumbar puncture, which shows improvement of their condition. And because that tap is what they need, you put in a VP shunt to keep it going. But just as we talked about with vascular dementia, the presence of hydrocephalus alone is not enough to make the diagnosis of normal pressure hydrocephalus. Because as you have diffuse cortical atrophy in Alzheimer's disease, the size of the skull is the same, the size of the brain shrinks, the ventricles are going to expand to compensate. So the presence of hydrocephalus does not mean NPH. The presence of strokes does not mean vascular dementia. It is the presence of the stepwise decrease from vascular dementia that causes you to think vascular dementia. It's the wet, wobbly, and weird and improvement with LP that tells you it's normal pressure hydrocephalus. In general, incidence and prevalence alone, Alzheimer's is going to be the answer. So let's run through this one more time to close this out. Alzheimer's disease, memory first, Down syndrome, diffuse atrophy. Pick's disease, personality goes first, memory then, frontotemporal degeneration on imaging. Lewy body dementia is going to be Parkinsonian symptoms and dementia, vascular dementia, stepwise decrease in cognitive function with each stroke, Creutzfeldt-Jakob, someone who's young and has myoclonus with dementia, and normal pressure hydrocephalus, wet, wobbly, and weird. That is dementia.